Welcome to The Explainer. Today we're taking a deep, clinical dive into a topic that touches millions of lives, but is honestly so often shrouded in misunderstanding, and that's substance use disorders. By treating addiction as the complex physiological reality that it actually is, we can better understand what is happening in the human brain and body, and more importantly, how we can effectively treat it.
Think about the drinks we casually have at dinners or celebrations. Now, consider this number, 178,000. That's the estimated number of alcohol-related deaths that occur every single year in the US alone. It's just a staggering statistic, right? It really brings into sharp focus the lethal potential of substances that are deeply woven into our daily social fabric. This isn't just about bad habits. We're talking about a massive public health crisis that requires a structured clinical response.
Okay, let's dive right in. Here's our roadmap for today. First, defining addiction. Second, the impact of alcohol. Third, the opioid epidemic. Fourth, stimulants and club drugs. And finally, assessing and treating addiction.
Part 1. Defining addiction, a medical condition.
To really grasp addiction medically, we gotta get our vocabulary straight. For the longest time, society just framed substance abuse as a lack of willpower, but modern medicine, it has formally established it as a diagnosable condition governed by specific clinical criteria, and it all starts with intoxication. Clinically speaking, intoxication is a reversible pattern of significant maladaptive changes in behavior, thoughts, or feelings caused by taking a substance. So it's not just being high or being drunk, it is a temporary, chemically induced alteration of your brain's normal baseline functioning.
Now, as a substance is used repeatedly, the body actually adapts. And this leads to two huge physiological concepts, tolerance and withdrawal. Tolerance simply means the brain is adjusted to the drug, so you need increased amounts of that substance just to hit that original effect. And because the body has adapted to functioning with the drug, taking it away causes withdrawal. We're talking about highly uncomfortable, sometimes incredibly dangerous physiological and cognitive changes that hit when the substance levels in your blood drop. These two forces basically lock the user into a vicious cycle.
So how do medical professionals actually assess the severity of this cycle? They use the DSM-5 addiction criteria. When a doctor is evaluating a patient, they aren't passing moral judgment. They're looking for concrete signs of impaired control and physical dependence. Are they using more than intended? Is there a persistent inability to cut down? Do they have intense cravings, neglect their core responsibilities, or continue using despite obvious physical and mental harm? Meeting these criteria is exactly what triggers a formal clinical diagnosis of a substance use disorder.
Moving to Section 2, the impact of alcohol beyond the social drink.
You know, alcohol is uniquely deceptive because it is just so socially acceptable, but its destructive capability often exceeds illicit drugs. Interestingly, the medical danger it presents is vastly different from opioids. We all know the immediate lethal danger of an opioid overdose. It depresses respiration to the point where someone stops breathing. But get this, the true lethal danger with alcohol, as well as barbiturates, actually comes when the user tries to stop. Unlike most other substances, unsupervised withdrawal from severe central nervous system depressants like alcohol carries a massive 10% mortality rate. It is incredibly dangerous to just quit cold turkey without medical help.
Let's walk through the actual clinical timeline of alcohol withdrawal, because it is terrifying. The early stages, which are often just dismissed as a bad hangover or the shakes, can begin just 4 to 6 hours after the last drink. But for someone who is physically dependent, this can rapidly escalate into hallucinosis, generalized seizures, and finally a condition called delirium tremens or DTs. DTs are a full-blown medical emergency characterized by severe delirium and autonomic instability. That basically means the body's basic vital functions just spiral out of control.
But it's not just withdrawal. Chronic alcohol abuse literally damages the brain's physical structure over time. A truly devastating example of this is Wernicke-Korsakoff syndrome. See, alcohol prevents the body from absorbing essential vitamins, specifically vitamin B1 or thiamine. The first stage of this, Wernicke's encephalopathy, involves severe confusion and a loss of muscle coordination. And if it's not immediately treated with intravenous thiamine, it progresses into Korsakoff psychosis. That is an irreversible alcohol-induced dementia characterized by profound amnesia.
Section 3. The opioid epidemic, a national crisis.
So opioids, they fundamentally work by depressing the central nervous system, providing heavy pain relief, but driving immense physical dependence. To really grasp the scale of this public health emergency, just look at the nearly vertical climb of that gray line. While deaths from prescription opioids and heroin have kind of held steady or even declined a bit recently, the death toll from illicitly manufactured synthetic fentanyl has just spiked exponentially. It's an undeniable, highly lethal shift in the entire landscape of illicit drugs.
Now, because these synthetic opioids are incredibly potent, reversing an overdose requires immediate, and I mean immediate, intervention. Enter fast-acting narcotic antagonists like the Zimhi Naloxone autoinjector. This is designed to instantly counteract that respiratory depression caused by opioids. It essentially kicks the opioid molecules right off the brain's receptors and restores breathing in an emergency.
The absolute most crucial point here: anyone can learn to use this tool. You could literally save a life in a coffee shop or on the sidewalk with this. The method is incredibly straightforward. Press, push, pull, place. Press the needle firmly into the outer thigh. Push the plunger down until it clicks and hold it for 2 seconds. Pull the safety guard down over the needle immediately. And finally, place the used syringe safely back in its case and call 911. It's just a simple clinical procedure that is saving lives every single day.
Section 4. Stimulants and club drugs. Hijacking the brain. If depressants slow the body down, stimulants do the exact opposite. They overexcite the nervous system, forcing this massive release of dopamine and hijacking the brain's natural reward pathways. Yet, statistically speaking, marijuana holds the vast majority of illicit drug usage at over 83%. By comparison, heavy stimulants like cocaine sit at about 6.7%, and meth is around 3.5%. But listen, while their slice of the pie might seem smaller, the clinical devastation and the extreme hyperarousal caused by these specific stimulants are incredibly severe.
The clinical outcomes of these drugs are wildly different based on their chemical makeup. Heavy stimulants like meth or cocaine cause extreme hyperarousal, sky-high blood pressure, and long-term damage to your dopamine receptors. In stark contrast, date-rape club drugs like GHB or Rohypnol are these stealthy depressants. They cause severe memory impairment, respiratory distress, and swift, dangerous unconsciousness, which obviously makes them incredibly dangerous in social settings.
Section 5. Assessing and treating addiction, the path forward.
Okay, we've explored a lot of the physical damage these substances cause. Now we have to pivot towards solutions, right? Treatment isn't just a single event, it's a structured, step-down approach known as the care continuum. A patient usually starts in detox, where their acute, physically dangerous withdrawal symptoms are managed in a closely monitored medical setting. From there, they move into residential rehabilitation, then step down to partial hospitalization or intensive outpatient programs, and eventually transition to standard outpatient treatment. This structure ensures that as a patient gains sobriety, that medical safety net slowly adjusts to support their integration back into daily life.
And this whole continuum relies heavily on day-to-day maintenance. Doctors don't just rely on behavioral therapy alone. They use specific pharmacological support to chemically assist the brain. Medications like naltrexone actually block the physical cravings for alcohol. Disulfiram operates on classical conditioning. It causes a highly unpleasant toxic reaction if alcohol is consumed. Meanwhile, methadone and buprenorphine act as safe, controlled substitutes that manage opioid withdrawal without producing that damaging illicit rush, which is huge for preventing relapse.
Which brings us to our final thought for today. As you've seen, intoxication, tolerance, withdrawal, they aren't just abstract ideas. They are actual physiological mechanisms that physically rewire the structure of the human brain. The damage is clinical, and so is the treatment. So if we know for a fact that addiction alters the brain's very anatomy, how can we as a society better support lifelong medically assisted recovery? It's really something to think about. Thank you so much for joining me for this explainer, and keep asking the right questions.